Okay. So this is just a really nice, another amazing case. Of pelvic pain.
I feel like I was seeing more DIE from from the torus of the uterus to the colon.
Yes, right. So there's this big, deep infiltrating implant right there, and it's pretty extensive actually. It goes there, and it goes right here, and it goes down pretty far right there. It's like I think I measured like 6 centimeters or something like that in the craniocaudal dimension right there. This is not really a mushroom. I guess it's more like the dumpling one that Maria showed before. Um, or not dumpling. What do you call that? That Asian crispy.
Wonton?
Yeah, the wonton or whatever. The thing that has the note in it. The like, oh, how, you're gonna be great or whatever. Those little notes.
Mhm.
Um, you know what I'm talking about? God, I can't
I
like
vaguely remember her saying something, but obviously if we can't remember it.
the cookies, Chinese cookies, those cookies,
Oh,
whatever.
fortune cookie.
Fortune cookies. The fortune cookies right here. See the fortune cookie sign. But it was for small bowel. But anyways, it applies here. Okay. So anyways, what else? Where else? What other sites? Right here. So there's another big plaque right there, anterior to the uterine.
That's like what Anu was talking about last time, where it's coming from the outside. So there's like space under the like myometrium underneath it.
Yeah. So anyways, this is just like stage 4 DIE and really great, not just, in the cul-de-sac where it's most common, but you can also see it along the anterior. Actually anywhere, everywhere, right?
Okay, hold on. Okay, so I have like a few adrenal cases, and I'm just gonna I'll go back and forth with Nelly, but let me try to. Okay, so there was this mid-sized adrenal mass, like 4.5 centimeters, pretty heterogeneous. It had these kind of T2 brighter areas. And then this is the in and out of phase next to each other. So there's definitely parts of the mass that have dropout, which would be most suggestive of an adenoma. Occasionally, you can get microscopic fat in adrenal cortical carcinoma, not usually in pheos. So it was still suggestive of an adenoma, although given how large and heterogeneous it is, it's probably going to go for resection because they usually get resected after 4 centimeters, where there's a higher risk of malignancy. So this ended up coming back as an adenoma with myelolipomatous degeneration. And so we said like, well, myelolipomatous degeneration, like a myelolipoma. And we were wondering, like, maybe are these areas here where there's only etching at the periphery, is that the myelolipoma part? So then we looked at the T2 with and without fat sat, and we couldn't really convince ourselves that it was like satting out like tons of fat in there. But I would argue that maybe there is some dropout here. And that area, I'm just going to point out, like this whole cystic area is on the CT. I'll show you what it looked like on the CT, and just tell me if you think is this area here where it looks almost like there's like more fat in it. So I wonder in retrospect if this was the myelomatous portion of it. And the reason I bring this up is because I used to think that anything that had bulk fat in it was a myelolipoma. And at SAR, I learned that it has to have greater than 50% fat to really be called a myelolipoma. But if it has just like small foci of fat, it could be an adenoma with myelolipomatous degeneration. And the reason it's important is because if you just call something a myelolipoma, they won't do an endocrine workup. Whereas if you call something adenoma with small areas of fat, they would do an endocrine workup. Are you guys following along my train of thought here? So I'm not saying I would ever maybe prospectively have called it, but I guess what I learned at SAR was that even if you see, and I don't, this isn't the best example, but even if I saw like small foci of fat, I used to call that just like, oh, that whole thing's a myelolipoma. And what I learned is if it's like less than 50% of it, then and just small areas of fat, it may be actually an adenoma with myelolipomatous degeneration and may need an endocrine workup.
Sorry,
And
can I go ahead? Yeah.
No, my question is if you put ROIs on that CT, is it lower than 0 Huntsville units or no?
Let me see. This is where it's confusing because I feel like sometimes, oh yeah, it's minus 34.
Yeah.
So it's not the cleanest fat, but
Mhm.
it's measuring minus 30, minus 34.
We don't have non-cons, do we? I mean, I don't know if it makes a difference, but so you're saying that, so this case, let's say we saw this this thing, right? Like if I saw this, I would say an adenoma, because I don't see big blobs of fat. But we're saying that, and that's, if you see something that looks like an adenoma, that you say is adenoma if there's less than small, like half or a quarter. But if you see, go ahead.
Yes, exactly. So I used to think like if
And it
you
needs to be macroscopic fat, not
Exactly.
intralesional microscopic fat. Like in this case, I wouldn't necessarily say there's, I mean, I guess there's a dot here and there that looks like macro, but mostly I would have attributed to intralesional fat. So, but if there was a larger portion, what was it? Fourth, one half?
I think it was, if it's like, it has to be more than a half of it has bulk fat.
Okay, if it has, then you could just
myelolipoma.
blow it off and say it's myelolipoma. Otherwise, it could be adenoma with like myelolipomatous components,
Yes.
which still needs a workup
Endocrine.
for.
Yeah.
And what did you guys say prospectively on this case?
We said it favored to be an adenoma, but given the size and heterogeneity, cannot exclude malignancy. I think like with the degree of, and also most of the time when it's greater than 4 centimeters, they get resected anyway.
Even if it looks benign?
Yeah, I think so, because ACCs can have intravoxel fat or microscopic fat. So this is the debate, like, and well, the other thing is, especially when they're this large, they definitely need the endocrine workup part of it because they can have Cushing's disease. But actually there was an endocrine surgeon at SAR, this whole size thing is a little bit also now on the move, because it used to be like, okay, well, there was an 80% rate of malignancy if they're greater than 4 centimeters. And now it's like, well, if we really think it's just an adenoma and the endocrine workup is negative, could we just watch those? So this ended up getting resected.
Gotcha. Yeah, I would just watch them. Okay. This is a patient with transaminitis, has a history of a condition that I'm going to withhold for now. Prior CT non-con was negative, and this MR is being done for transaminitis.
I see multiple liver lesions. I want to see
Yeah.
other, but like they look
Yeah.
kind of evil gray-y, so I'm
Yes.
concerned about like.
Okay, and here's your diffusion.
Mm-hmm.
Good. There's the one. And then, actually, I'm not going to withhold it in history. A history of multiple myeloma.
EMD, extramedullary disease, plasmacytoma.
Yes, yes. So that's exactly what this thing's turned out to me. So it's really hard to see on the post-con, but I think I saw them really well on the T2. So it went on to get a biopsy. So that evil gray right there, there's multiple actually. There's a little one like there, right there.
That's crazy how much you can't see them on the post-con. Like
there's patient was also, there's a lot of motion too.
Yeah.
So it's hard, but it's not. It's much easier to see on the T2. So I think that was, I diffed it, and it was plasmacytoma from patients known multiple myeloma. So anyways, add in your differential in when the patient has the right history.
Yes. And I learned that EMD term from Rupa because they have a lot of that at Arkansas. So EMD is extramedullary disease.
Oh, okay. Why can't you just say
Plasmacytoma. I don't know. For
yeah.
some reason, they call it EMD. Maybe when it's more like because it could be non-mass like, you know, I think it's a larger term, like more encompassing term.
Okay.
Okay, this is another adrenal mass, and I want you to tell me what you think it is. It's also about 5 centimeters. These are both courtesy of Melina. Thank you, Melina. Fairly T2 bright, and it's got like either necrosis or cystic spaces within it. This was out of phase and in phase, and I'll just say that there was no convincing microscopic fat. Then this is the arterial phase, pretty avidly enhancing except for those cystic spaces, and more delayed phase. So what do you think? Anyone?
It doesn't look good.
Okay. So what do you think it could be? So this one, we put the primary differential, that is what it ended up being, which was a pheochromocytoma. So it looks really good for a pheo, actually, especially they like having these cystic change within it. It's not actually necessarily necrosis, it's cystic change. And it was very avidly enhancing. I think ACC is still, you know, in the differential here. Interestingly, this patient did not have significant hypertension. And one more thing that I just wanted to bring up is the path report actually gave it a pheochromocytoma and adrenal gland scoring scale. It's called a PAS score. I'm going to try to bring it over into the screen here. But this is the score it was given. And basically they look for diffuse growth, cellularity, pleomorphism, and they add up all these numbers, and it gave it a PAS score of 4. And so therefore they said this tumor may behave in an aggressive manner. So this is the way that they stratify pheochromocytomas. Like, you know, when we say 10% are malignant, we can't really truly prove they're malignant until they develop a metastasis. But this scoring system kind of helps give you, you know, say like, okay, this is a more aggressive tumor. This, you know, needs to be followed very carefully rather than a low PAS score. Okay.
History of VP shunt, and this is an outside study. I had a revision at somewhere else and had nausea and vomiting. And this is a scan that was performed at the outside facility.
It's going into the bowel.
Yeah, isn't that like, look at that.
Wow. Seems so smooth. Like there's not much irritation in the area.
Wait, what is this, a catheter?
A VP shunt. It was revised
Jesus.
somewhere else. And then this
Oh my
imaging was
goodness.
done somewhere else after a revision. And patient
Oh my
has
goodness.
nausea and vomiting.
Yikes.
And this was submitted for reinterpretation.
I wonder what the long-term consequence of that is, like having CSF go into your bowel. Like, it doesn't seem like the worst thing in the world.
Well, yeah, I don't know. I don't want CSF anywhere near my bowel. If it was up to me, but
Yeah.
anyways, this is an intracolonic placement malposition. This was a case for my colleague Cameron Adler, and it happens when the VP shunts are placed without the assistance of general surgery. So I guess non-general surgeons do them too. So, and urgent emergent revisions are usually required, and it can lead to meningitis.
Can't it just erode into bowel over time too? Like, because it doesn't have a coiled end, so it has like a pointy end, or, you know, like a blunt end. Like it's not necessarily happened when it was placed, right?
Yeah, I think that's a good point. The revision itself was not done like very recently. So maybe this is one of those where it eroded into the bowel. I don't know. We don't have
Yeah.
pre-placement.
Cool. Okay.
All right. So this is a 27-year-old woman. It's not an, not an eye test. You can see big lesions. It has enhancements, right? It has areas of washouts.
I'm sorry, how old is the
Mhm.
patient again?
She's 27.
20,
She's a young
okay.
woman, right? So you can see has enhancement, has washout, right? See these areas, washout. And then there's not much. It's an older case, so I don't have diffusion. Unfortunately, you can see there's no fat. And then on T2. So far, what are you thinking?
I think it could still be an adenoma.
Yeah, given the age,
uh,
and I would
yeah.
put adenoma first, but can't exclude.
Fibrolamellar HCC and HCC, which HCC would be weird, but I mean, I feel like you still have to add it.
Right. So this is
And
like
it's funny because it looks like it's displacing stuff. Like is it? I mean, I'm like wondering if it's like a
no,
primary
it is
parenchymal.
it is liver.
And okay.
Let's see if I can get the coronals up.
It just has mass effect, I guess. Yeah. Biopsy. Tissue's the issue.
Right. Right. So you can see it here. It comes off from the liver. So if I told you that this patient has chronic Hep B, you would say it's HCC, right?
Yeah, you have
Right.
to.
It has
Yeah.
enhancement, right? Enhancement, washout. So it would make it a lot. If we said that she has history of, OCPs and adenoma. Anyway, I agree. This needs biopsy. She didn't have any history of any prior, and this is neuroendocrine tumor met.
Wait, new
So
diagnosis?
This was a primary neuroendocrine, or it was
Wow.
a met, but from unknown primary.
Yeah, can you go down into the right lower quadrant? Just want to make sure there's nothing in the mesentery bowel.
This is as far as it goes. Hold on a second. Let me just get this there. So I only bring it up is because, again, just to drive home the point how important it is to apply the Lyra's criteria in correct patient population, because, in a patient who has, high enough pretest probability to get HCC, this would be diagnostic of HCC, but in a young, healthy woman with no primary, with no predisposing factors for HCC, then this appearance is, let me stop sharing. This was an interesting case. Or did somebody else want to go?
No, you can go. I was saying, but I was muted, that I feel like I get tricked all the time by neuroendocrine, like, I guess in the end they need a biopsy regardless, but whenever it comes back neuroendocrine, I'm like, damn, why didn't I put that in the differential to begin with? Because enhancing and washing out, it can be neuroendocrine, so.
Oh, yeah.
But they're not
So,
common. like you're not gonna just
I feel like
add
they're
that.
more common than I.
They're very common.
Yeah.
I
but
don't know.
then it's hard to.
I have skewed perspective of what's common or not, but we see them all the time.
That's exactly how I feel.
Wait, so would you be adding
it?
it on your DDX now? Like I don't know that I would. Like what? It's adenomas, AGCs, and neuroendocrine tumors?
I mean, that's the differential for hypervascular mass. But
But the pretest probability of neuroendocrine tumor is like not as high as adenoma, right? In this patient population.
Yeah, I think adenoma would still be at the top.
Yeah, I mean, with this appearance, that would be my number one choice, right? 27-year-old, no prior disease anywhere, and it's so large and so.
Nelly, for me, one of the reasons to think about it, maybe, I don't know if I'm going to add it into the differential every time, but one of the reasons to think about it is sometimes the primary is on your exam. And I've seen that missed a lot where people just didn't look into the right lower quadrant to see the primary, like mesenteric nodal met and the primary, so that's one reason where in retrospective, I was like, oh, I should have thought of it, So
yeah, that's a good point. As I'm talking, I'm like, oh yeah, I've seen so many cases of hepatic neuroendocrine tumor on this case conference. Maybe I should add it to my DDX then.
And like Victoria said too, like I'm confused about if it's common because we see it all the time, but we're a referral center. So it is,
Right.
I'm going to try to look it up while you're talking about how common it is.
Okay. All right, I'm going to take out the overlays. Right. Okay, so this is a newly diagnosed with breast cancer patient right there. And on a PET, she was found to have this very avidly active thing that was not seen anywhere else. So it was the only place of disease. So appropriately at the PET, they thought that they were dealing with metastasis. So we got a PET MR for further assessment. You can see, you can see that there's definitely a lesion here. Okay, you can see that the lesion is. You could see. There you go. You can see that the lesion has diffusion restriction.
Sorry, patient has history of what again?
Breast cancer.
Breast cancer. Okay.
Breast cancer. Right. So the patient, their arterial phase is done super early, so you can't really see any enhancement, but that doesn't mean much. This is the portal venous phase, kind of becomes less enhancing, and then kind of disappears. So there, you can see right there. So they, this is the only site of the disease. Sorry.
Sorry. Can you pause it really quick, Aarti?
Yeah. So it was the only site of the disease. So at that point, they decided to biopsy it. You can see that they actually did it with PET guidance, interestingly. But they, I'm just kind of showing that they were in the correct area, and they really did a bunch of shots in the area.
Wait, I didn't know you could do
back.
biopsy with PET guidance. That's cool.
I did not know either, but they did.
Okay.
This is with PET guidance.
So why PET and not diffusion? Because they're restricted like crazy.
So right. So they had, and I only know this for Tuesday because we had this conversation last week. They ran out of MR compatible needles, so they can't do MR guided biopsies somehow. But this was done under PET guidance. So there's let's see if I can bring it up. But you can see here they biopsied a bunch. I was trying to get.
And I guess you can't really use contrast enhanced ultrasound, right? Because it wasn't really enhancing.
Well, I don't know. I don't believe we have contrast enhanced ultrasound, but you can see it.
And that would be super tricky spot to look at the dome, but wow, that's super cool.
This is how they, right. So anyway, so the pathology came back as no evidence of mass forming lesions, just some inflammation, and follow up probably 4 months later. MR, there's a little bit of susceptibility there from the tract, but basically you can't. Why is it doing this? You can see there's a little biopsy tract that you can see here, right? And that's it. So it's all gone. So we think it's just some sort of weird inflammatory tissue tumor that she had.
Wow, that's annoying. A PET avid liver lesion in a breast cancer patient turns out to be a pseudotumor.
I have few inflammatory pseudotumors which look really horrible diffusion. They look aggressive, they look bad, and then they just disappear. It's pretty interesting. And then my last, just again remove the
Okay, go.
Okay, so the patient came to us like this with the diagnosis of the diagnosis was of intrahepatic cholangio. That was the diagnosis. Oh, not intrahepatic, sorry, cholangiocarcinoma, Claskin. You can see that, you know, the initial, this was outside CT that was, we had to reinterpret. So you can see, you know, there's, you know, buildup. You can actually see nicely like a mass, hyper-enhancing mass, which is, you know, which is nicely surrounds the common bile duct. We did the MR. Now you can see here again, we still see the buildup. We see nicely the, you know, the circumferential thickening of the mass. They re-biopsied it at our institution, and this came back as IgG4 autoimmune cholangitis, IgG4 related cholangiopathy. Patient was.
I'm sorry, what cholangiopathy? UG4?
IgG.
IgG4.
Oh, IgG4. Oh, God.
Wait, can you
Yeah.
show the pancreas some more? Because apparently 90% of those patients have a pancreatic abnormal. Oh, the pancreas is totally abnormal. See how like it looks sausagey and like the duct is beaded?
Yeah, look at that.
So in
Look at that.
IgG4 cholangitis, apparently 92% will have a pancreatic abnormality. So that's the clue. There, this is less striking, but it still looks sausagey there.
It does look sausagey.
Yeah, with
Especially
like a
this
little
part.
fibrotic rim.
Yeah. I just want to bring up the follow-up. But I'm trying to do it in a way that I don't flush anything. With just with, let me just take another takeaway. The overlay. Here we go. Extend this. So this is the original one. And see again this mass-like thickening, and this is now after the course of steroids. You can see all that is gone. And yeah, and I agree. The pancreas doesn't look as bulky anymore. Okay.
Cool. One more question. Can you show that MR of the bile duct again? I just want to see, does the rest
Okay.
of the ducts look like beaded kind of?
Hold on, let me just. What do you think?
Kind of.
Hard to judge.
Yeah, because I was just wondering.
I mean,
if,
the pancreatic duct is really abnormal. I agree with you.
Yeah. Can you show like the axial haste or they do look beaded there. The reason I bring it up is like there is a sort of mass like part centrally, but if the rest of it's beaded too, then you're like, oh, maybe it could be. I mean, just in retrospect, like maybe it could be a more sclerosing this kind of picture.
Right, but then you would think that, okay, what if it, you know, then you still would think that this is sclerosing cholangitis with, you know,
like primary,
you know,
but rather than secondary.
Right, like with cholangio.
Yeah.
Right, so it's hard.
Yeah.
But you
I think
can
the
see it,
pancreas is the clincher.
Right.
Cool.
I agree with you. Very cool.
Okay. This patient had pain, pelvic pain, and abnormal ultrasound findings.
Ooh, is that the black Garland sign?
Yeah, I know, right? Isn't it like amazingly beautiful?
It's beautiful.
So
pretty.
I know. I didn't know about this until my first case. And I, you know, it's bilateral, kind of this dark rim around the ovaries. And I'm like, what is this? I emailed Cookie and she's like, oh my God, what a beautiful case. And my response was, beautiful case of what? So this is a black Garland. Yeah, this is what it looks like. And it's a benign condition. I guess it can lead to hirsutism and, you know, all these kind of patient had pain, but menstrual irregularity, pain, hirsutism, and virilization. And you get this T2 dark think my example is better than this one, but this is from AJR case report. But yeah, mine is better. Yeah, this too dark, thickening around ovaries, and both cases that I've had were bilateral. So yeah, just another example.
Beautiful one.
Black Garland side.
Okay, I'm continuing my adrenal theme. This one is a patient who had a right renal cell carcinoma resected. So they had a right nephrectomy, and then they had this enlarging lesion in the left adrenal gland. The lesion did not really have microscopic fat, or even if it did, it doesn't matter because RCCs can. So enlarging blobby mass in the adrenal, we're thinking this is an RCC met. The reason I bring up this case is because there were several reports where we said we did not see, the right adrenal gland was not visualized. So I just wanted to bring this up because it became an issue, because when they were considering resecting the left adrenal metastasis, the oligometastasis in this case, it was going to make a big difference for the patient and for a couple of intraoperative things if the right adrenal gland truly wasn't present. So, just looking at this, we can actually see that there is this Y-shaped thing here. It looks like there probably is an adrenal gland here. Even though in the chart, there was a history of like nephrectomy and adrenalectomy. We said like in retrospect, looking at this, there probably is a right adrenal gland here. The reason it makes a difference is if there was no right adrenal gland and then you were going to resect the left adrenal gland, you would basically be making that person go into an Addisonian crisis because you would have no cortisol. And so the anesthesiologist wanted to start cortisol intraoperatively, and the endocrinologist wanted to give cortisol, for the rest of the patient's life if there truly wasn't a right adrenal gland. So it makes a difference clinically. Look carefully. And if you think that there is one, even if they say radical nephrectomy, or there's anything about adrenalectomy, if you think you see one, then report it because it could possibly be there. And sometimes they do partial adrenalectomies, and they're not super consistent about reporting if they did a partial. So then the pathology report might even say adrenal gland visualized, but it might only be a part of the adrenal gland. Any comments? It seems like a subtle thing, but it actually was a big deal clinically because they really didn't want to start steroids intraoperatively or, say the patient had to be on it for life. Now they've removed this left metastasis and the patient is producing cortisol still. So we know that there's a right adrenal gland. Okay.
So history, of an abnormal finding on CT, abdomen and pelvis, and they got an MR.
That's a wacky thing coming off the prostate.
Yes, so this was a CT, and the patient had a stone. It was a stone protocol, and then they noted this thing and recommended a prostate MR, and that's why the prostate MR was done. Okay, and then diffusion. And these are calcifications that we saw in this CT, these dark stuff. Okay.
It looks like a lot of it is T2 dark, like almost like a fibrous kind of thing.
Here's your post subtraction is here.
Oh, it's not really enhancing. Or maybe one little nodule.
Little nodule here, maybe. I don't know.
Is that just a massive cyst? Some sort of pertinacious cyst? Hemorrhagic? No,
It almost looks like a fibroid.
it's not enhancing.
Yeah.
So this turned out to be leiomyoma, prostate leiomyoma.
Wow.
Yeah.
Nice.
And
why isn't it enhancing? It's like an infarcted one.
I think it's like
myeloma.
I don't know if it's torus. It doesn't look torus to me, but again, I don't see a lot of. I mean, I don't know. What do you think?
I just think it died for some reason because, like, maybe it was.
did. I mean, you can. What about
Oh.
degenerating? Wait, where's my T1?
Well, I did say it looked like a fibroid, which is a
You
line.
did.
So maybe
You
it was
did say that.
like a degenerated.
Degenerated.
Yeah.
Here's a pre. little bit of hemorrhage along the margins and superiorly.
Cool.
Yeah.
So what did they do? They only resected this thing, or they left the prostate alone, presumably.
Yeah. No, surgery, just right now they're just looking like they're not surgeons. They're not resecting it.
Oh, they just biopsied it.
Yeah.
Got it. Cool. Awesome. Okay, I'm gonna close out for today. See you guys later.
Thanks all. Bye.
Bye.